Yeah. Um, Today I'm trying to cover the topic benign carcinoma of the larynx. And in our Department of ENT, is one of the commonest area, and everybody is supposed to know each and everything as about carcinoma of the larynx, which is commonly seen in our country. Especially earlier, smoking is one of the commonest situation we see, especially so in males. Very rarely we see in females. Probably if at all we see it is because of passive smoking, or if not, some people, some areas do smoke chuta and other things. That will also can give rise to carcinoma larynx in females. There are some sort of subdivisions in the larynx. One is supraglottis, other is glottis, third one is subglottis. The supraglottis area covers supraglottic or if not suprahyoid epiglottis, infrahyoid epiglottis, aryepiglottic folds, that is the laryngeal aspect. And aryepiglottic fold has been considered as a marginal area of the larynx. The laryngeal aspect of the aryepiglottic fold is taken as a part of larynx, but also arytenoids and ventricular bands, otherwise called as false guards. The glottis constitutes true vocal guards, including anterior and posterior commissures. Subglottis is the area below the or under surface of the vocal cords. So incidence of the cancer of the larynx in relation to subsides are supraglottis is 35%, glottis which is most common and high incidence is 65%. Subglottis is found to be 1%. Now the hypopharynx is the area which is closer to the laryngeal inlet. In that perimucosal lesions are 55%, pharyngeal wall is 20%, post-record area is 50%. I was just telling you, aryepiglottic fold has been considered as a marginal area. So instead of that, if the marginal area, that is aryepiglottic fold, is affected, we treat that case as a carcinoma hypopharynx. What are the risk factors? Alcohol, smoking. Um, Also, the alcohol and smoking is like a adding fuel to the fire, and only 1% of the laryngeal cancer can occur in non-smokers. I just told you just now, possibly because of passive smoking. Alcohol will give rise to supraglottic carcinoma, and there is a viral etiology has been attributed, that is human papillomavirus of 16 and 18, and there is genetic susceptibility is also been mentioned, and gastroesophageal reflux has found to be one of the causatives. It should not be forgotten nowadays. They are found to be one of the reasons in many areas of the ENT, especially even up to the pediatric sinusitis and also sort of restrict and tube problems also secondary to GERD. Prior history of head and neck irradiation also matter to be considered, especially all benign lesions must not be irradiated. Any cancer of the thyroid or something can give rise to this sort of radiation following sequelae, post-irradiation sequelae. Diets lacking green leaf vegetables, fruits and fiber, diets rich in salt, preserved meats and dietary fats, occupational metal, plastic workers, exposure to paint, exposure to diesel and gasoline fumes, exposure to asbestos or otherwise called as asbestosis, it will lead to more of a lung cancers. Before that, it can be possible to have a laryngeal cancers. Exposure to radiation has been mentioned. What is the pathophysiology? Physiological factors are mentioned already. After that, carcinoma is squamous cell lining of the larynx. Squamous cell lining is already been seen as a normal thing. The type of the carcinoma is nothing but a squamous cell carcinoma. Very rarely we get a adenocarcinoma. Rapid metastasis of the carcinoma due to the abundant lymphatic vessels into the regional lymph nodes and also one cell secondaries. But there is an exception. Supraglottic cancer rich in lymphatics, whereas glottic cancer doesn't have much of lymphatic drainage. It is otherwise regarded as a barrier. So blood cancers do well, very less propensity to go for regional lymph node metastasis. So blood is again a possibility. Late arrivals will be there. By the time patient comes, it already spread to the mediastinum. These are our observations. What are the histological types? One is, if you know the normal lining of the larynx, definitely the commonest one is your squamous cell carcinoma. Next is verrucous carcinoma, fibrosarcoma, chondrosarcoma, minor cerebral carcinoma, adenocarcinoma, wood cell carcinoma, and giant cell and spindle cell carcinoma. Out of that, squamous cell carcinoma must not be forgotten. A variant of this squamous cell carcinoma is various verrucous carcinoma, which is radio resistant. Treatment is surgery in those cases. What is supraglottic cancer? It is a less frequent than glottic cancer. Majority of the lesions are seen in epiglottis, that is supraglottic area. These are the subsides. Epiglottis, false guards, followed by ariepiglottic fold in that order. It may spread locally and invade the adjacent areas like radicula, tongue base, and pericarpus. And pre-epiglottic space involvement through foramen in the infrahead epiglottis is being mentioned. Paraglottic space involvement through the mucosa of the ventricle. These are the areas related to the larynx. One is pre-epiglottic space, other is paraglottic space. When you talk about the extension or spread of the glottic cancers, these are the areas through which your glottic cancers spread. Clinical features of the supraglottic cancer. These are the diagnosed late because of they don't produce symptoms very early, and there is a lot of space for the tumor to grow and doesn't really cause struggle for breathing or respiratory embarrassment. Common clinical manifestations like pain in the throat with rheumatologia and muffling of the voice if tumor size is large, dysphagia if tumor involves the arterioepiglottic fold, or discomfort in swelling. Swelling of the larynx if the laryngeal framework is involved, cervical lymphadenopathy in the upper deep cervical lymph nodes. Hematogenous spread is not so common. Propensity by spread by lymphatics. This is a very classical picture showing the supraglottic cancer. The lesion in the supraglottic area, that is the infrared epiglottis, found to be having a sort of irregular growth with some sort of exophatic appearance. Glottic cancer is more common. It is being mentioned as 65%, and it has got an anterior commissure, vocal process of the arytenoid, ventricle, and false guard. Downward is subglottic area. These are the areas which can spread. And the area of maximum impact will be there in anterior one third of the vocal cord and posterior two third junction. So what is glottic cancer? So how does it present? Hoarseness of the voice is the commonest symptom. Cough with irritation in the throat. There may be an ulcer or growth over the vocal cords. Mobility of the vocal cords is impaired or vocal cord is fixed. This is due to invasion of the thyroarytenoid muscle, cricoarytenoid joint, or perineural invasion of the recurrent adenoids. Respiratory obstruction with stridor and very common presentation. And lymph node spread involvement is very rare because it is nearly free from lymphatics, the vocal cords. That's why the propensity for lymphatic spread is practically minimum. This is just some sort of pictures mentioning about early carcinoma of the right vocal cord, carcinoma involving the antecommissure, and extensive carcinoma of the left vocal cord, starting from antecommissure to the right. Subglottic cancer. This is one of the things. Late arrivals will be there. Prognosis is relatively poor compared to other two. Spread superficially, submucosally to the opposite side, or downwards to the trachea may invade. So anteriorly, cricothyroid membrane, thyroid gland, and muscles of the neck. And it can go to the lymph nodes, which is seen to the extent of 10 to 34%. So what are the symptoms? Stridor is the earliest presentation. Hoarseness is the late symptom, as upward spread to the vocal cords is late. spread is always towards the mediastinum. By the time we notice, it will become inoperable. Subglottic cancer. This is a rare form of laryngeal cancer. It is manifested by the following clinical features: portions of voice if vocal cords are involved, respiratory obstruction with stutter as the tumor becomes larger, cervical lymph node involvement, prelaryngeal and paratracheal lymph nodes are involved. Spread is quite rapid. By the time we investigate the patient lands, invariably it will get affected. This is the classical picture mentioning about subglottic area involvement. So this is little indolent by the time vocal cords involvement is not yet being seen or noticed. Diagnosis of laryngeal cancer includes the following steps. History taking very important. Later on, examination of the larynx by indirect laryngoscopy and followed by direct laryngoscopy. Examination of the neck for the metastatic lymph nodes. Radiological examination of the larynx by X-ray and CT scan and radiological examination of the chest to find out the secondaries. Histopathological examination of the tissues from the lesion obtained by direct laryngoscopy can be done under local anesthesia, general anesthesia. Local anesthesia is not preferable. Child, the individual may not cooperate, so preferred choice is general anesthesia only for better evaluation and to get a better specimen for biopsy. There are some classifications, AJCC and TNM classifications have been mentioned. So supraglottis malignancy has been further divided into T0, T1, T2, T3, T4, A and 4B. It all depends on the set of involvement. The glottic, same thing, T1A, T1B, T1, T2, T3, T4A and T4B. So out of all, the more area, more concerned is T3. Whatever may be the region, supraglottic, glottis or subglottis, vocal cord fixation is the criteria. Thereby, we can say the cord is not fixed, it is lesser than T2. If it is fixed, it is T3. Either supraglottis, glottis or subglottis. This is one of the distinguishing situation. T3 means cord fixed. Subglottis again, same thing T1, T2, T3, T4, T4B. So again T3, we notice fixation of vocal cord is the criteria to put under T3, whether it is supraglottis, glottis or subglottis. Regional lymph nodes have been taken into consideration and it is classified accordingly. Like annex, this cannot be seen. N0, no regional node metastasis clinically. N1, simple node, single node of less than 3 centimeters diameter. N2A, 3 to 6 centimeters diameter, largest lymph node. N2B, multiple ipsilateral less than 6 centimeters. N2C, bilateral, contralateral nodes and less than 6 centimeters. N3, more than 6 centimeters. It may be ipsilateral or contralateral. Distant metastasis has been taken as a criteria to put under metastasis. That means MX cannot be assessed. That means metastasis cannot be assessed. M0, it is distant metastasis. M1 is distant metastasis. M0 is no distant metastasis. It is clinical evaluation. Stage of the situation. Basic thing is stage 1, that is T1 M0 M0. Stage 2 T2 M0 M0, which is considered to be early stage. And stage 3 T3 M0 M0. And stage 4A, stage 4B, stage 4C has been considered as advanced stage. Treatment. Treatment of laryngeal cancer falls into the following categories. Number 1 is no treatment when the patient's condition is not possible to treat. Number 2, palliative treatment. Symptoms can be managed. Number 3, curative treatment when the patient's condition can be treated and that is either surgery or radiation. Last is after surgery, whatever it is, rehabilitation to gain the function is the primary requirement. Under the following headings, we need to consider whether there is a supraglottic, glottic or subglottic. No treatment. You have already understood when I told you no treatment means inoperable or chances of survival is remote. 70 to 80% of the patient with carcinoma may have advanced stage. advanced lesion and presentation with distant metastasis. If they are not conscious of pain, they don't require any treatment. The pain will be taken care by means of opioids, thereby the pain can be relieved. This is one of the areas to be considered. Anyway, it is being mentioned that inoperable, so nothing much to be done. Next comes is palliative treatment. It is given for the patient with advanced cancer, but main strategy of suppression of the symptoms without intent to cure. It may involve pain relief, psychotherapy, combination of radiation, surgery, and chemotherapy. Tracheostomy is done. Patient develops a respiratory obstruction. Curative treatment for supraglottic cancer, radiotherapy or supraglottic laryngectomy is the primary treatment. For recurrences of these cases, total laryngectomy is the treatment of choice. 90% of the glottic cancer are cured by radiotherapy. For recurrences, hemi-laryngectomy or total laryngectomy is needed. In the case of subglottic cancers, radiotherapy is the primary modality of the treatment. For recurrence, total laryngectomy is the treatment of choice. I was telling you, the glottic cancer has got a better prognosis compared to the earlier other two, whether supraglottic or subglottic. Provided earlier uh, diagnosis is done. This is the flow chart to mention about the management of the various types of cancer, supraglottic cancer, glottic cancer, subglottic cancer, which includes some sort of lesion management with lasers also, and later on partial laryngectomy and total laryngectomy and rehabilitation. What are the rehabilitation procedures? For partial laryngectomy, patient speech therapy is advised, and there is an entity called organ preservation. It is to be focused. At the same time, when you want to sacrifice the larynx, there is loss of speech, and the function of the larynx is gone. And in those cases, you have to go for a rehabilitation. That is um, sort of processes whereby rehabilitation for speech is a matter of concern. For total laryngectomy patients, the rehabilitation involves development of esophageal speech, speaking through tracheoesophageal fistula and electrolarynx. And in this situation, tracheostomy is also mandatory in some cases. So definitely, we need to think of it. Permanent tracheostomy is the one where there is a total larynx is removed. There will be complete opening. It is permanent. So definitely, it is a challenge. Definitely, we have to advise the patient not to go for swimming, that sort of things. Otherwise, the patient will choke in this. The patient will have a problem of choking when he enters water. Tracheostomy is an operative procedure which is an opening made in the trachea and this opening converted into stoma on the skin surface. A step in the operation in which opening is made, trachea is called tracheostomy. Again, tracheostomy is divided into temporary tracheostomy and permanent tracheostomy. Whereas in the case of total laryngectomy, the tracheostomy is permanent. There will be some sort of problems, limitations will be there. So I just happen to tell you not to enter the waters. Sphincteric action is taken off, voice is also lost. This is the schematic representation mentioning about tracheostomy tube is in place, thereby bypassing the obstruction element and direct access into the trachea, thereby ventilation can be achieved, and later on it is to be maintained by means of moisturizing the air, and also humidification is also mandatory. And there will be loss of sensation of the smell, and also taste is possible, and the speech is lost. In these cases, we have to go for speech rehabilitation by means of processes, that is finger blown processes and such sort of things. Products are all available while doing laryngectomy. We do insert this sort of processes, thereby patient can have a legible speech. And this is the schematic representation mentioning about bypassing the obstruction element in larynx, whereby the ventilation is maintained, your direct access to the airway by means of putting an opening on the tracheal rings and inserting a cuff tracheostomy tube is inserted. This is the schematic representation and it bypasses obstruction. And this is the individual after tracheostomy and it is to be maintained. Whether permanent means you have to keep it forever, or if not, mm, the patient will get used. He can close the opening and he can try to speak. These are the few things. and it is very important to maintain the tricuspid tube. What is laryngotomy? Again, a matter of little difference. The procedure is done for respiratory distress. It is done to save the life until anesthetist can come and do a intubation, or if not, ENT surgeon can come and do a tracheostomy. Just nothing about it. Got it? Uh, what about the opening is made at the cricothyroid membrane. Just take a needle, stab it, open it, and take a tube and put it there. That's all. And the technique, the cricoid cartilage and lower part of the thyroid cartilage are palpated. Cricothyroid ligament is palpated. Then horizontal incision is given the cricothyroid ligament. And the surgical blade number 11. Incision is widened with a handle of knife and kept widened until the resuscitation measures are taken. This is just an emergency laryngectomy. A very simple procedure. Anybody should be in a position to take up this test to save the life of the individual. Right? Thank you. Okay, I can speak. These are the few things you have to keep in mind while uh, discussing about customer larynx is one of the commonest area. We should be in a position to know each and every aspect, how to manage. And the tracheostomy is the one procedure everybody should know in detail, depending on the depending on the situation. It must be emergency tracheostomy, and it is a simple procedure, and it will bypass the obstruction. With this tracheostomy, the total airway is cut down to the uh, dead space is cut down to 30%. Directly you have access to the trachea, and thereby humidification element is taken off. The functions of the nose is bypassed. Thereby you have to maintain humidification. Otherwise there will be a lot of crusting. The maintenance of the tracheostomy is the most important thing, especially earlier few days. So there is always a problem of secretions, that is tracheoria they call it, and crusting is again a possibility. The types of tracheostomy tubes are also mandatory to know. So depending on the situation of the condition, life-saving by tracheostomy, and later on maintenance, and again rehabilitation of the speech is mandatory. So earlier we used to do laryngectomy, and later on now the concept is totally changed. Try to do procedures like organ preservation. Nowadays we are getting laser techniques to do cortectomies, and later on maintaining the integrity of the anatomy of the larynx, whereby organ preservation is possible. Early intervention is mandatory. The quality of life is improved. Patient will not have any sort of depression by losing his speech. Of course, the sphincter action of the larynx is secondary to the patient, but phylogenetically, sphincter action of the larynx is the first one, followed by your voice. The primitive animals don't have much of good speech. Human being is the person who is having a speech as a sort of one art. So this is one thing. Nobody wants to. Communication is important. Speech is mandatory. Larynx is important. Without it, we cannot have a legible speech. With all these things, preservation of the larynx is mandatory. Nowadays, management of the customer larynx is done by either radiation or chemotherapy, or if not, laryngectomy surgical procedure. That too, conservative surgery has again come into the scene.